research tool. I think that we are going to be using this more and more even the neurologists, because apparently there are some medications that are in research and development for stroke. So I think we are going to be using this more to stratify patients. So which is the patient that is going to need aspirin only, which patient is going to have the new medication or a combination. So I think this is going to be more applicable to making decisions on treatments. So basically, when they try to figure a way to assess the patient, they have they call it 4 factors on that thing that I gave you. Basically, four types of domains in the neurological examination. So as you know, we have the 2 hemispheres. There is some functions that are more predominant in one hemisphere compared to the other. That concept is also changing because we're seeing now that there is a lot of interaction between the 2 hemispheres. But a stroke is a good example where you have lesion to a very small area and you can have specific deficits. So when you see the hemiparesis on the left side of the body, you know that the motor cortex is affected on the right side. So we're looking at different phases of the brain. We're looking at the left cortical, and this has to do more with the higher function of the brain. So we have the cortex on the left hemisphere. We have the level of consciousness. That's when we ask patients questions, and also when they do commands. So when they follow the commands, so that's how we assess the level of consciousness. And then we talk about language, which is the ability to form sentences and to understand questions. Then we have the right cortical, which is has more to do with the horizontal eye movement. So when we have a large stroke and people have their eyes deviated towards the left, that's what we're looking at in terms of the horizontal eye movements. The visual fields, of course, it can be on both sides. Of course, you can have a right homonymous semianopsia because you get a left cortical infarct, and that's cortical also. But this is looking more at the frontal region when you assess this portion of the exam. And then extension and attention, we can go more in detail on that because that's a higher functional examination. And then the more basic function will be sensory. So, for example, you could have a person that feels when you touch each of the extremities, so the sensory pathways are preserved, but they do not have the association and the cortical function associated with it, and that's when we talk about extinction. So for you to test extinction, by definition, you have to have the sensory function, so that's not the same area of the brain. This will be more of the association cortex that is affected with extinction, and typically that has to do with the right parietal hemisphere. So if somebody has extinction, then you know it's a right parietal lesion most of the time. It doesn't have to be 100%, but most of the time. And then we also have the motor. So on the handout, they say right motor, left motor, and then they say right arm, right leg. I think that's a little confusing because when you're testing the right arm and right leg, you're testing the left cortical area, the left, the motor strip. So I'm not sure why they say right motor, right arm, and right leg. I think they should have switched the side, but the point is still the same, that when you're looking at the motor function, you're looking at the muscle strength in the arm and the leg, and then we're looking at dysarthria. So dysarthria compared to aphasia, that's a very important distinction. Dysarthria is the motor component of the speech. So it's the ability to move your muscles in the mouth and the larynx to produce speech. Aphasia is the production of speech, but that's a higher cortical function. So that's your ability to make sentences. So one way that I think about it, if somebody's having a few drinks, when you have the first couple of drinks and they're tipsy, they're dysarthric, so their speech is slurred. They still know what they're saying, they still understand everything, but you can tell that it's a little dysarthric. When you get more drunk, then you don't know what you're saying, right? You go nuts and eventually you pass out. So being more drunk, that would be more of an aphasia. It's not exactly the same, but that's how I think about it. So aphasia would be more that you can, the muscle movement of the mouth is okay, but it's your higher cortical function that is affected. So they could say things that are clear, but they don't make sense. So or they have a lot of effort. So when we have an expressive aphasia, people have a lot of effort to pronounce or to say the words. So you can tell that they're frustrated because they cannot, it doesn't come out right, or they misplace words or say the wrong thing. With dysarthria, they don't have that effort to talk, but it's just slurred. So that's a motor function. And they have it under the right side. It could be also on the left side, but most commonly it's on the right side of the brain. And the left motor, you have the weakness in the arm and leg. So one common question is, what happens if somebody is intubated? How do we assess the score? So one way that I was thinking about it, if somebody's in the emergency room and you do the baseline score and they can talk fine, you know, there is no dysarthria, and then they also have COPD, they get intubated because of pulmonary failure. So that's not really a neurological underlying problem, but now the patient is intubated, they're in the pulmonary care unit, and you want to repeat the NIH score. So for that patient, I will not give an additional point because now they have dysarthria. So with dysarthria, somebody's intubated, you cannot give a point because you just can't test it. So they put this U or UN and test it or unable to test it.
And it tells you, well, UN is intubation or physical incapability, like maybe their mouth is wired shut. But other than that, it's always testable.
Yeah. So in that case, I wouldn't say that the NIH score is getting worse because they're intubated. We know that the underlying condition is not a neurological condition. Now, if the patient is more lethargic, of course, then that you're gonna get a point on the other level of consciousness. So that's the difference. Now, if somebody is intubated and you want to test for aphasia, so they cannot tell you, so what we need to do is have them write a sentence. Because if you do not have aphasia, you know, you cannot express yourself, but also because it's a higher functional, high cortical function, then you should, if you have aphasia, you should not be able to write full sentences, and the sentences are not going to make sense. So that's one way that you can test the patient for aphasia.
What if they're sedated?
Yeah. So sedation, you know, the sedation with this research tool, of course, that was not accounted for people getting sedated because that's how it was designed.